right. Thanks very much. Appreciate it, Saxon. And nice to see everybody again. And this is episode 2 of our mental health expose for BSN Sports. This one's going to be on eating disorders in athletes. I'm going to go ahead and share my screen and we will get going. All right. Can everybody see that and hear me?
Yes.
Okay, fantastic. Because last time was a little bit difficult. All right, so it's on eating disorders in athletes. It can be a pretty dense topic. I'll try to make it relevant to the coaches and parents in the room and athletic administrators. Disclosures, none. What are we going to learn today? We're going to hopefully recognize the signs and symptoms of eating disorders within the sports context because eating disorders are more prevalent in athletes. We're going to hopefully learn about how they affect both health and performance, which I know a lot of you are concerned about, but getting at the underlying mental health concerns that an athlete may have actually will help secondarily their performance. And then finally, we're going to learn how it really takes a village to both screen for and treat eating disorders and talk about utilizing a return to play protocol. So first off, trivia question. What are the 5 sports that have the highest risk of developing eating disorders? I'll let y'all go ahead and type a few thoughts into the chat. So wrestling, we got swimming, wrestling, running, gymnastics, rowing. Y'all have hit 3 so far. Cross country. Okay. So we got a smart audience. Yep. Okay, let's see what the survey says. Rowing, gymnastics, figure skating, cross country, and cycling. So y'all did a really good job. So if you notice that there's different components to each of the sports that are listed, and we'll get into kind of the reasons behind that. But one is weight class-based sports tend to have a high prevalence of disordered eating, and you can think about that. We'll talk about rowing specifically. Gymnastics and figure skating both are under the quote aesthetic or appearance-based sports, which factor into how they're graded. Certainly, they have a higher prevalence of disordered eating. Cross country and cycling, both of which there's an advantage to having a lower body mass, but there's a threshold there. Also have a higher prevalence of eating disorders. So there's a spectrum of eating behavior where there's certainly optimized nutrition, but eating disorders, full throttle eating disorders, meeting DSM-5 criteria, they can creep up if there's any sort of disordered eating or as far as an athlete's approach to the way in which they're fueling their body. You're going to learn that we talk about later in the presentation about low energy availability and how truly optimized nutrition for sport is a math equation. So if we're expecting to expend more energy, we're going to have to appropriately fuel for that. And if your body is chronically at a deficit, you actually set yourself up for failure. And even though you may not have eating disorder cognitions or a drive for thinness, you're setting yourself up for something called relative energy deficiency in sport, which is its own unique disordered eating kind of system, which is separate from the generic anorexia, bulimia, binge eating disorder, which we'll talk about. So what's the difference between disordered eating and eating disorders? Well, eating disorders is where you have some of the primary criteria often and obsessive and precluding normal function, where there's actual functional impairment and a preoccupation with healthy eating that leads to significant dietary restriction. Disordered eating is not quite to that extreme, but certainly can get there. It's where you have, your thoughts about food aren't necessarily occupying all of your time. It's where functioning still remains intact, and where you have a preoccupation with healthy eating, but it's still in an acceptable level, but you still have to be careful. This is an important slide. So if you don't really take much home other than this, you'll just note that there are basically 5 primary types of eating disorders that we see in our young athletes. But an easier way to think about it is you have your 3 camps. You have your restrictive eating disorders, you have binge eating, and you have your cyclical eating disorders. So again, all about the math equation. So anorexia nervosa is important to talk about because it's the deadliest of all mental health disorders. It's the one where you can have re restriction about what you put in, but also with what goes out. It comes in different forms. So there's restrictive, binge purge type, a variety of that. But it's where someone can be incredibly underweight, or in a young person failing to meet their growth chart needs because of a nutritional deficit. Bulimia, another one that you may know pretty well. It's where you have that cyclical pattern of either restrictive eating and or um, as a result of it's a compensatory behavior to binge eating. So what is a binge? A binge is what anybody on this call would agree is eating an exorbitant amount of food all at one time, like more so than just eating like a few slices of pizza and ice cream. I'm talking about eating a whole pizza, maybe a burger, maybe ice cream, and then topping that up with other junk food, and also then having an associated sense of um, low self-worth and low self-esteem or hiding in shame as a result of that binge. As long as it happens once a week, up 1 to 3 times per week, three times per month, you're meeting criteria for binge eating disorder. There's another one called ARFID, or avoidant restrictive food intake disorder. That's the one that's only really been around for 10 years. It's basically anorexia minus any eating disorder cognitions. These folks aren't actually cognitively trying to lose weight. They're just the ones that simply can't keep it on, or they have a block with trying to get food in. They're either chronically underweight or nutritionally deficient without any sort of supplement. Tend to see that a lot in young people, especially. There's a crop of folks that have sensory related issues or on the autism spectrum that are more likely to get ARFID. It's not as common in our athletes, but that being said, it can crop up at any age. It's not just in young people. A classic example would be someone going to like a family reunion, choking on a piece of food, and then struggling with no longer being able to eat either that item or other things, and then as a result, losing weight. And then there's the bucket of other specified feeding or eating disorders. That's where you have disordered eating symptoms that are causing functional impairment, but they're not neatly fitting into one of the other disorders. So what are some of the signs and symptoms of eating disorders that we actually worry about? Well, as you can see, it affects all body systems. And don't worry about the medical jargon. Just note that some of the highlights of where it can actually affect someone. It obviously can cause fatigue, low energy, if you're not getting that energy availability. It can cause oral and dental concerns. Actually, in fact, dentists are sometimes the first people to diagnose an eating disorder when they notice that someone's teeth are being affected by maybe purging behavior. You can get the chipmunk cheek look with parotid gland enlargement when the parotid glands are overused from purging. They actually increase in size. So it actually causes even more body dysmorphia if you're engaging in that, which then makes it actually become more cyclical. The ways to dampen that down are either to stop purging, which would be the obvious answer, or to use ice packs to help with swelling, or to suck on like a jawbreaker or some kind of gum to help with that pain. Other body systems, the GI tract is the biggest one. When you've been restricting for a long time, if you have anorexia, one of the problems is that your gut slows down and kind of forgets how to work well. So they're very much prone to constipation, which makes them not really want to eat anymore. And they're also probably at a fluid deficit, which makes them even more prone to constipation and feeling bloated and just simply not well and not wanting to eat. So again, it becomes a pattern that's hard to break. It can affect fertility, bone health, concentration, cardiac. The most important and most deadly part of the side effects is that when you aren't appropriately feeding your body, it lead to your heart not working well. You get floppy valves. Your heart's not nearly as strong. You have arrhythmias. Really, really dangerous stuff. In fact, it's cardiac related concerns that's the killer for those with anorexia. I said the bone fracture. Anybody know why those with anorexia may be prone to bone loss, especially in the female population specifically? Yes, Jake. Nobody. Okay, that's right. It's because the ovaries aren't working as well, and they actually have an effect on. There you go. Perfect. Decrease in estrogen. So it's affecting actually bone health, and then it can cause electrolyte disturbances, especially if you've been abusing either laxatives or purging, which causes a loss of potassium, which is extremely dangerous. There's an example about someone a young, healthy female, otherwise healthy appearing female that shows up at the ER. If they have an isolated low potassium level, it's more likely than not that they've actually been purging. So it's something to be considered. And I don't want to go too far into the weeds, but just note that every single body system can be affected by disordered eating. Let's see if I can. There we go. So why are athletes particularly at risk? So it's the fact that there's a lot of variety of reasons. Let's go over a few stats and then we'll talk about why. Prevalence in eating disorders in athletes is significantly higher, roughly 4x that of the general population. So 18 to 20% versus 5 to 9%. Um, Male athletes specifically have a higher prevalence than those in the general public. Used to think of it as a 10-to-1 ratio, that eating disorders were more female in nature. I think we're just waking up to the fact that men have just men and male identifying folks have been kind of silently suffering, thinking that they couldn't come forward with a lot of the body image distress they've had. If you find that social media has kind of taken over and there's more of a social comparison aspect, there's been much more eating disorders that have been present. There's an old study in Fiji that had been done that prior to the advent or the bringing on of cable television, they had basically no eating disorders in the country. Maybe they also weren't looking for them. But after that, within a few years of cable television coming in, their eating disorder rate in that country were at or above Western society, like the United States. Pretty telling how there is sort of a biopsychosocial effect, that social aspect to disordered eating coming up. But in sports, it's a competitive place, and with increased competition, there's more disordered eating. Athletes also don't really talk about their mental health concerns, and so despite the fact that the numbers we see are pretty strong, I think they're actually higher because I still think that athletes are coming forward with what's going on. So important to note, sports don't cause them. It's the environment that sort of allows them to blossom. Disordered eating still occurs more than eating disorders. Lean sports have more disordered eating than non-lean sports. In time, while there might be a short-term boost in performance if someone has cut weight, they will absolutely cause a negative effect on an athlete's health and performance. And just participating in sports, because of just the way things go, it can complicate folks identifying them unless you're looking for it. So prevalence in female athletes, look at that. Almost 33% of female elite athletes reported eating disorder. That's a lot. Nearly half in lean sports, nearly 20% in non-lean sports. Mind you, this is for 2 to 7% U.S. collegiate athletes overall. 42% of those in athletic sports, 24% in endurance sports. Those are some pretty high numbers. Male athletes, similar thing in relative to the non-athlete population. You have 8% of male athletes versus 0.5%. So those that are doing anti-gravitational sports, as you think like the rings and stuff in gymnastics, weight classes for sure. Rowers specifically are the extremely high prevalence rate, where it's even more so in men than in women. I think it's the population that gravitates towards rowing, but also just the fact that they have to maintain a certain amount of weight to be on that boat. So general risk factors, this is a non-athlete population. What can you can sort of spur it on? So genetics, just your general personality, body image, your peer group, your use of social media, or if you've been exposed to bullying, isolation, your gender, and also if you've had any sort of chronic disease or a history of trauma. I mean, there's a lot of factors that go into this. One of the things I talk about with the families I meet when we're first diagnosing an eating disorder is that it's really not so important and really unhelpful to think about the cause. of the eating disorder at the time that they come into my office. Because at that point, the toothpaste is already out of the tube. We need to focus on treatment. Because if you think about too much about the cause, it can actually place a lot of blame, where you get stuck thinking that it's your fault, but when you're actually the person who needs to be helping get this person back on track. So a lot of times I'll talk with parents like, okay, whatever happened in the past and you think maybe you're responsible for it, I need to drop it. I'm going to absolve you for any guilt you may be feeling because I need you to really focus on helping feed your starving child. This is when we're thinking about restrictive eaters like anorexia. Because family-based therapy and FBT, or the Maudsley model, is the gold standard for treating anorexia nervosa in adolescents, especially in young athletes. And athletes, especially even up to 25, they're more infantilized and more like the adolescent population because they've been working for someone and someone's been in charge, like a coach. So you really can use that team, if you will, that's been built to your advantage to help them get on track. So sport-specific eating disorder risks: training, injuries, body comp testing. What is the norm on the team? How is it being even messaged by your teammates and by the coach? What's the performance like? What's your athletic identity? Has there been any big changes, or as we said already, injuries? So this is another big takeaway. Eating disorders should be viewed as invisible injuries, just as other mental health concerns are well. But you can think of it as an invisible metabolic injury. It's no different than if you broke your leg. You wouldn't expect someone to come back from a broken leg the next week, would you? It's basically the tendonitis of physical injuries. It's going to take a long time to recover. You have to actually have a lot of patience needed for that healing. And yeah, there is a little bit of uncertainty about regaining the prior level of performance because there's always going to be that thought in the back of your head, okay, is it sort of going to creep back up? But that's why with weight restoration and with therapy and a review of the importance of sport in the person's life and with their body image, we can get somewhere. What stuff could also go along with eating disorders? Well, there's a high prevalence of depression and anxiety. And in fact, 2 studies confirm that nearly half of folks with eating disorders have clinically significant depression and anxiety and substance use, as you can see. So there's some similarities between being a good athlete and having eating disorder traits. Like, you could be like mentally tough, but then if it goes too dark, be like severe self-discipline. You can be committed to training or it can become excessive. You can be pursuing excellence or it's perfectionism. You can be incredibly coachable or overly compliant. You can be unselfish or selfless, and you can perform despite pain or just deny that you have discomfort. Same with exercise pathology versus wholesome exercise, but there's a clear split. If someone is like, for example, someone misses a workout and is concerned, that's fine. If they're missing a workout and they become distressed, if they're more flexible and open versus being rigid and closed-minded, something to look at. If there's a compulsion or an anxiety to continue training through illness and injury, that's pathologic. Or if they're simply doing it to alter their appearance or to regulate discomfort they're having versus using it to challenge themselves or engage in stuff that they enjoy, that's a pathologic versus it being wholesome. So other stuff to just consider with athletes and body weight pressures. Again, a lot about it is messaging. So it's super important that we're talking about this today, and I really appreciate what you do. Everybody on this call, coaches, administrators, parents, and whatnot. It's how you frame disordered eating and how you talk about how people look in the locker room. We'll talk about how if you're going to have to do weigh-ins for your sport, it would be great to do it in a private setting, not to be having bulletin board material about everybody's weight to keep track. It is a private conversation and also should be probably done with a doctor present rather than just with the coach. Sometimes can be a competition within the competition. This is sort of the cultural aspect where actually the athletes themselves will talk about body comparison and have some shaming, especially when there's revealing uniforms that and that can lead to a whole host of concerns, especially in the aesthetic sports. So just kind of keep all of this in mind. More body image related information. Body image is defined as the internal image someone has of their body and the evaluation of that image within the athletic context. It's super common within athletes, and there's several studies have reported that athletes who dieted frequently and used pathogenic weight loss methods despite being satisfied with their body. So they're still doing it despite being satisfied. So they're at higher risk. Um, Eating disorders are more prevalent in lean sport, as we talked about, than in those with non-lean sports. But non-lean athletes report more body dissatisfaction and the use of bad weight loss methods, which shows that eating the symptoms in lean athletes may be more due to the demands of the sport than due to body image. So take that in. So when you have the lean sport athletes, those where it's low body mass advantageous, those have eating disorder symptoms that are developing from the sport itself. Whereas when you have the non-lean sports, if they have eating disorder symptoms, this makes sense. It might be more due to body image distress, and using the methods of weight loss that way. Takeaway from this slide is that 70% of weight class sport have the prevalence rate of disordered eating. I mean, there's really no way to deny it. If the need to meet specific weight requirements is a giant risk factor. So the way I look at it is, don't try to fit a square peg in a round hole. If an athlete's natural body type simply isn't going to fit into that weight class, then don't have them try to cut. The whole concept of cutting 10 to 15 pounds of water weight in a short period of time is just mind-blowing to me, that someone could think that that's healthy, with all the electrolyte challenges that can come from that, and how that can be incredibly dangerous for your heart. Especially with having watched documentaries about boxers and whatnot, it's really eye-opening that this still is happening, when probably the person should be simply either fighting at a higher weight or competing at a higher weight, where they're not being forced to, quote, maintain an ideal weight or shape that they don't fit. The last part, as I mentioned before, weigh-ins can be particularly stressful. So team physician or athletic trainer should be actually conducting those weigh-ins. So messaging, got to just reframe the culture, normalizing healthy eating behaviors and modeling that for the athletes. So the takeaway here is that we want to install regular, adequate, varied nutrition that optimizes health and performance. And that if there is someone like in female athletes, we don't want to have it them wear a badge of honor where they've lost their period, thinking that that's a good idea from low energy availability. We actually want to make sure that they are trying to maintain all of their body systems online, because it's really important to performance as well, which we'll actually talk about specifically with amenorrhea and performance. So here's a multidisciplinary team. This is the village, as I was talking about. It takes really everybody around them. This is be kind of like what surrounds the athlete. You got family, you got the dietitian, possibly, certainly coaching staff, you have the athletic administrators, you have the trainers who are really on the front lines, are the ones who can actually do a lot of that initial kind of recognition that there may be some kind of disordered eating pattern going on. As far as from a treatment perspective, if there's an athlete struggling with an eating disorder, you have a family therapist who's actually doing a lot of the coaching aspect at home to deal with mealtime. So whenever we have someone who is, especially an adolescent, who's struggling with anorexia, who's simply not getting in the calories they need, and there's a block where there's that externalized eating disorder voice is telling them not to eat at mealtime, which notice how I framed that, the external voice. You got to split the athlete from the eating disorder. If you think about it as the same person, it's unhelpful to recovery. If we separate the two and we actually talk about the eating disorder being its own entity as an unwanted guest in that person's home or in the locker room, then we can actually all band together, including the athlete themselves, against the eating disorder. And it also makes it a lot easier when you hear that venom at mealtime, the refusal of wanting to eat, for family and parents who then have a lot of guilt. They don't want to harm their kid, to make them eat because, that would hurt them, when obviously that doesn't make any sense. If the eating disorder thrives on that distress. So you want everybody to band together. There can be a role for some individual work with a psychologist once someone is weight restored to help with that body image distress, and then do some retroactive, trauma-based work or whatever that led to someone maybe developing the disordered eating symptoms. This actually brings up a great point. So, are eating disorders about food? No. Eating disorders are about control, which is somehow they have come up because it's a primitive way, especially for an athlete, to be able to control what goes in and what goes out when they may not have control over other areas of their life. Especially when their athletic identity may be a core aspect, and if they're not able to perform or whatever, the eating disorder is unfortunately a maladaptive way to deal with that stress. So disordered eating flowchart on when someone's actually identified. You got the people on the front lines. Anybody can identify this. This is why we're talking about these signs and symptoms. And then when you do, the idea is to engage that core multidisciplinary team, the ones that flowchart I showed you above. Really important to get them referred to a primary care physician who can do the medical monitoring. The really important stuff like getting the height, weight, vitals, backwards facing weight, so the athlete is unaware but also not stressed out by having to do it in a probably in a Johnny or some kind of consistent garb. So there's also no throwing of weights that can occur when someone knows the weigh-in is coming. And also they shouldn't be water loading. So you monitor their fluid intake ahead of time. The reason someone might water load is that if they're underweight or the eating disorder knows that they're underweight, they're going to have a weigh-in. They don't want to look as if they're still underweight, so they put on the extra fluid weight, which is not helpful from a metabolic perspective. And it can have a false weight at that weigh-in. So you do random weights. Once you have that medical assessment, then you can send out referrals to an eating disorder professional who can then triage to what level of care they may need. Most of this can be dealt with in an outpatient clinic, unless they're so medically compromised that they need to go to the hospital to get fluids or some kind of nutrition because maybe they're not able to really eat orally. So that's when you would help them in other ways. I moved out here to Colorado to work at Eating Recovery Center, which is one of the bigger eating disorder residential and higher level of care facilities in the country. And they have branches everywhere. It's one of many that exist. But it has a full spectrum of care as far as what you can do if someone's not doing well enough in an outpatient basis that you could bump them up to an intensive outpatient or residential, which is essentially coming in, staying 24/7 in a hospital for many weeks to get weight restored, or if they're really sick, they actually can go to the medical hospital and be back referred. So I just wanted to paint some hope that if this is identified and it's first tried in an outpatient clinic and dealt with, fantastic. But if it's not, there are other options. So screening tools. How do we screen? This is just an example of things that can be used by a medical professional. You do not need to be using these tools, but these are out there. So there's 4 big ones that are used, especially in the sports space. That the beta Q is the one specific for athletes, but these are questions that you can use. Primary care physicians can use during their normal exam to just check in about certain disordered eating behaviors. Medical assessment's pretty thorough, and again, I know the audience I'm talking to. I'm not expecting you to take home like, oh my God, well, what are we supposed to check for? But just note that this is what they were looking at, which is pretty significant. Main questions though: general well-being, eating habits, like mapping it out through the day. Most eating disorder professionals use like a British model, talking about 6 times a day when someone might eat. So you have breakfast, morning tea, lunch, afternoon tea, dinner, and supper. That's the British method, otherwise known as 3 big meals and 3 snacks. That's typically how you would be able to fuel someone during the day, especially with athletes who tend to respond better to more frequent, smaller meals to continue being fueled. Really important. You'd also check in about compensatory behaviors. What's a compensatory behavior? That's when someone, if they're maybe binging, but then they feel guilty and they want to then remove the calories in a way, there are ways they could do that through purging, laxative use, diuretics, things that you need to actually be asking about, because the eating disorder is not going to tell you. They would be checking vital signs, height, weight, about their body image distress, what is their current exercise load in training, their family system, and just a general health. So that's a lot that's going to be dealt with in the first sort of primary care appointment. And then from there, they can go to an eating disorder professional who would work as a companion to them. Other stuff that would be checked as far as body systems, we've already kind of been over that. Biggest ones are the cardiac stuff. endocrine, especially in young females, whether or not they have lost their cycle or never have started. There's a lot of labs that can be ordered, unhelpful at this point, but just want to make sure that you know that, again, there's stuff that they're looking at. So when does someone need to go to a higher level of care? Well, again, this is a little bit into the medical weeds, but again, to tell you that this stuff's being considered when someone's ideal body weight is less than 85% of expected. There's actually thresholds by which you would look at that. So what is ideal body weight? What does that even mean? Ideal body weight is sort of a moving target, depending on someone's growth charts, is different than BMI, so the body mass index. So especially in sport and in eating disorders, ideal body weight is a more helpful measure. You can use BMI to kind of have a general sense of sort of maybe how underweight someone might be or overweight. But ideal body weight is the target by which we're looking. So if someone's always tracked over time on their growth chart since being a young child in the 25th percentile, they're just in the 25th percentile. There are reasons why everybody's on a spectrum of 0 to 100% of expected. But if they were always 75th percentile and now they're in the 10th percentile, that's a clinically significant change. Or if they were tracking over time and they just fell off a cliff, that's data for you to know. So you may find that they should be possibly at the 75th percentile. Maybe that's when they actually had their period, because you actually have to have enough body fat in order to have your ovaries tick on. So you want to be looking to see when that more normal body weight was, to know where we need to check back to. Athletes tend to be on the leaner side, depending, but it's a question that needs to be addressed. So why athletes with eating disorders need treatment? Well, I know y'all care about performance. Let's talk about it. So an athlete deteriorates psychologically without intervention. Performance eventually occur if they're not doing so well psychologically. From that, poor performance increases pressure. The eating disorder then itself becomes a way in which the athlete copes with the pressure. As the symptoms get even worse, the athlete isolates, and then we start back at the beginning. So it's just this vicious cycle. Okay, so let's talk about low energy availability and how this is unique to athletes and why it's an aspect that sometimes folks don't consider, because low energy availability is all about training load versus what goes in. Sometimes athletes, while trying to do the right thing to train, simply aren't getting in enough nutrition. So low energy availability can occur when there's like a misguided attempt to lose body mass or body fat, or if they simply don't know or have the resources or knowledge to meet the increased energy requirements of a heavy training load. So not, as I see on the other side of this, not all disordered eating involves sufficient or consistent energy restriction to meet criteria for that. So you can actually have disordered eating behaviors that have nothing to do with LEA. But overall, disordered eating is a common cause of low energy availability. So let's say that again. You can have a deficit on its own, or it could be due to a disordered eating behavior. Either way, if you end up with low energy availability, you're more prone to having that mismatch and having insufficient energy. So relative energy deficiency in sport is what occurs when you have that deficit. And that used to be, relative energy deficiency in sport used to be thought of as the female athlete triad. Over time, that camp ended up kind of morphing, because eating disorders can occur in more than just females. So it was a little unfair to just view it that way. But the female athlete triad was three things: low energy availability, loss of visceral function, and bone loss. Those three things. Super common thing to see in athletes. But it obviously affects other body systems, as you can see. So why do we care? So relative energy deficiency in sport is following a period of intense dieting, your VO2 max and your running speed will decrease. If you're not taking in enough carbs, you'll have early glycogen depletion, fatigue, and you start breaking down protein used as fuel. If you don't have enough protein, that leads to muscle weakness, wasting, and injury. And also in parallel, if you're dehydrated, that causes fatigue, poor performance, and more glycogen depletion. So this is like a real issue. So symptomatic athletes are apt to be malnourished, dehydrated, depressed, anxious, and obsessed with with this disordered eating, and which serves to decrease concentration in the athlete's ability to play or compete with emotion. We talked about what the triad is, basically the low energy availability, menstrual dysfunction, and bone losses for females, but red S or relative energy deficiency covers the spectrum of athletes. It's broader on arguably, to me, it's a better model to look at. Other performance consequences, there's a greater, if you have that deficit, you're at a greater risk of musculoskeletal injury, greater risk of developing a viral illness, and you have a lower hemoglobin mass response to altitude, meaning that when you're in altitude and training at altitude, you don't get the benefit nearly of that because your body system is not nearly as efficient. Here's one thing that I think is an incredibly interesting study that had been done a few years back. It looked at swimmers. All it did is compare a 12-week training program to 15 to 17-year-old female swimmers, those who kept their cycle and those who did not, were ovarian suppressed. Basically, I'll cut to the end here is that those who maintain their period actually swam faster, and it's clinically significant. So this, don't get overloaded by what's all on the slide. Again, this is just to show you that there are actual steps and criteria to use for a return to play protocol when someone has a deficit in their energy. But you first look at their health status, then you look at their participation risk, and then you actually make the decision with a team approach. But there's a lot of that evaluating health status as we look. There's a lot of body systems to check and labs to look at. It is a very thorough exam. Then you look at the sport modifiers themselves, like the type of sport, competition level, weight classes, kind of keeping that all in mind so that you individualize it to the person. And then finally, you want to have a good, full team, multidisciplinary team discussion about what this means and how to best support that athlete. There's sort of the red light, yellow light, green light concept of like who fits and where. Basically, if you got full-blown anorexia, you're in the red light. You're not going to be participating as of now until you're in a much better spot. The yellow light is when you have more red S features or low energy availability features that might be able to be dealt with. And the reason I'm saying that is that we're going to be talking about the SEAS protocol, the safe exercise at every stage protocol here in a second. The green light is if you have healthy eating habits, certainly you can play. So what is the Red S-CAT clinical assessment tool? This is, again, like a very easy, logical green light, yellow light, red light concept of who gets to fully participate in sport, who should be not competing, and also using a contract to be able to get back to sport. And what does that contract entail? Well, we'll show you in a second. Assessing readiness to reintegrate. So like once someone has been coming back from the eating disorder, we want to make sure that their medical complications are stabilized, clearance is occurring in stages, that they're actually able to comply with their meal plan, fuel themselves independently, especially for the demands of their sport. And they're probably working with a dietitian through this to help them. And they're also using new, healthy coping strategies instead of the disordered eating. And they're not really obsessed about exercise. So take home here, an athlete who's medically unstable should not be practicing or competing. So is exercise during recovery okay? Short answer, yes, but. So back in the day, and I was definitely in this camp, I thought that if you're exercising while you were underweight, it was just getting in the way of potential caloric. It was getting in the way of that math equation I was discussing. That being said, there is a way to view it to keep the athlete's identity in check, to build hope, to such that if they're at a higher stage on the spectrum of recovery, you want to start folding in the exercise and do it in a healthy way. the safe exercise at every stage. Folks have been thinking about this for many years. There's a fantastic group called Mind Body Endurance, led by Dr. Riley Nichols, who's a prominent sports psychologist in the eating disorder space who helped with all of that. I trust entirely. Um, the idea is maintaining identity, self-esteem, social support during treatment and recovery. Mind you, if someone's like medically compromised, you're not going to be having them exercise at that point. It's once they get to a higher stage in recovery. So it's a simple graded level system helping determine what level of exercise is safe. So it gives you like clear data. So here's that contract for getting back to sport. Who has to sign it? A ton of people, like from the physician, the dietitian, the therapist, all the way down to the team doc. But you can have other checks on that multidisciplinary team. You can add a coach, you can add parents, whatever. And then the requirements and goals are things they have to be actually hitting. Meeting with the therapist at relevant intervals, meeting with a dietitian. They're also being able to comply with their meal plan and fueling themselves for sport. So in summary, hopefully I finished fast enough we can actually have some questions. Sport does not cause it, but disordered eating can often develop in the context of it. Athletes are very much more at risk of developing eating disorders than the general population. Athletic identity does fit into this. So it's really important to keep that in mind. So athletes may feel misunderstood, fearful, or risk treatment dropout if their athletic identity is not being addressed. While often not immediate, eating disorders will impact performance over time and is not sustainable. Athletes with disordered eating and energy deficiency are at risk for serious health and performance consequences. Performance does not always equate to good health. Keep that in mind. And low weight does not make you faster, as evidenced by that swimming study. Understand and communicate that eating disorders should be viewed as a metabolic injury, kind of a chronic injury that should be viewed no differently than a physical injury. These invisible injuries are real. So please be patient with the athletes, modify the training, keep them engaged socially outside of at a practice so that they feel like they're still part of the team, and then collaborate with that group, as I was saying, so that to adequately support the athlete. Thank you. All right. Questions?